Hello, my name's Christian. I'm a third-year resident. My question for you is, what does it mean to be tanked up or dry? That's the question that plagues a lot of interns and residents in ICUs every single day. So let's take a look at a situation that happens every single day. It's 2 a.m. You're taking a nap with your intern.
Doctor, Bed 5's blood pressure is 50/30.
Now there are a few different ways to handle this call.
Level 5!
So we can impulsively give fluids and pressors, or we can think about this in an evidence-based fashion. So why do we care? Fluids are often the reflex response by many residents and interns to hypotension. Recently, though, many trials have demonstrated that positive fluid balance is associated with poor outcomes. A 2016 systematic review by Malbrain and Merrick of 11 randomized control trials and 24 observational studies showed a lower mortality in those treated with a fluid restrictive strategy versus a liberal fluid management strategy. We also know that according to another systematic review by Dr. Mishard, only 50% of critically ill, unstable patients will actually respond to a fluid challenge. So what does this mean for us? Fluid kills. So let's take a look at 5 different parameters that may, or may not, be helpful in assessing volume responsiveness. These 5 parameters are history and physical, passive leg raise, central venous pressures, inferior vena cava diameters, and pulse pressure variation. This may sound crazy in an era of electronic medical records, ultrasounds, and CT scans, but we have to start with the most economical and rapid method of assessing volume status, the dreaded history and physical. A systematic review in 2005 in an ED population with undifferentiated dyspnea highlights history of heart failure, paroxysmal nocturnal dyspnea, orthopnea, and JVD as the most important history and physical exam to obtain when diagnosing heart failure and volume overload in this population.
So step 3 wasn't completely useless.
Let's not take it that far.
Next, let's segue from physical exam into another useful tip that's going to require some muscles.
Passive leg raise involves raising the legs to a 45-degree angle and assessing for a 10% increase in either stroke volume, pulse pressure, or end tidal CO2. The idea is that raising the legs rapidly creates an expansion of volume from the mobilization of peripheral blood, therefore mimicking a reversible fluid challenge by what Dr. Merrick calls autotransfusion. A 2010 meta-analysis by Cavallaro et al., including 9 articles and 353 patients, demonstrated a pooled estimate for sensitivity of 89.4% and specificity of 91.4% for passive leg raise induced changes in cardiac output, irrespective of cardiac rhythm or ventilation mode.
Wait, this seems awesome and easy to do. What's the catch?
Well, the problem is that the excellent sensitivities and specificities are for measurements of cardiac output, which involve esophageal probes, some expertise with TTE, or multi-$1,000 thermodilution, pulse contour, or bioreactance devices. When using pulse pressure alone, the pooled estimate for sensitivity was 59.5%, and for specificity was 86.2%.
In medical school, they told us central venous pressures were very useful. Can we use this?
So let's talk about CVPs. The 80-year-old intensivist that still hangs out at Grand Rounds will talk your ear out about this, but we're going to be talking about some CVP waveforms. Just kidding. How useful a CVP is in a critically ill patient population that likely has systolic heart dysfunction, renal dysfunction, dynamic changes in venous tones, and thoracic pressures. The reality is that most agree that the CVP should not regularly be used to guide fluid resuscitation. A 2008 meta-analysis, once again by Dr. Merrick, published in Chest, discourages the use of CVP, demonstrating an area under the curve of 0.56. In this review by Dr. Shippey, he references a poignant graph referencing a blood volume versus CVP in 1,500 patients, and the lack of correlation between the two is apparent. You're probably asking yourself, why hasn't he talked about the inferior vena cava yet? Isn't that one of the most popular methods for determining fluid responsiveness? So intern, what do we see?
Looks like the IVC is pretty plump, with no respiratory variation. I'd give her a bolus.
So that's a very common misconception, but this is in fact the aorta. This is actually the IVC, as we can see the hepatic vein straining into it and it coursing directly into the right heart. Now, IVC collapsibility can be described in one word: controversial. On one hand, a number of papers have encouraged the use of IVC collapsibility for volume responsiveness. However, a meta-analysis by Pierre Corey highlights the questionable utility. So what is an intern supposed to believe? The key is the answer is not so black and white, and the factors that influence pressures on the IVC are multifactorial. Positive pressure ventilation, adequate tidal volumes, the generalized vasodilation of sepsis are just some of the few common ICU issues that can impact IVC diameter. Once again, is it useless? In a specific patient population, it can be helpful. Pulse pressure variation is a dynamic measure of the interaction between the respiratory cycle and the cardiac cycle via the Frank-Starling curve. As a patient is being ventilated, there are cyclical changes in the loading conditions of the left and right ventricles. Blood pressure goes up during the inspiratory phase of mechanical ventilation and decreases during expiration. Unfortunately, the patient must have consistent cardiopulmonary conditions. Most importantly, the patient must be in normal sinus rhythm and ventilated mechanically with a tidal volume of at least 8 cc's per kg. Being as many of our patients in the ICU have irregular rhythms such as atrial fibrillation, the utility of this is somewhat limited. That being said, a pulse pressure variation of greater than 12% is strongly associated with volume responsiveness. So that was a lot of information. What can we take home from it? While none of these methods is the best answer, using some combination of them in the appropriate clinical settings could help us to make the correct decisions for our patients. So what have we learned, Albert?
That Dr. Merrick has literally authored half the literature on this topic.
I mean, yes, but what else?
Fluid kills, nothing's perfect, and use a little bit of everything.
Very good.